Welcome back. Today we are going to be learning about beta blockers. Which is a very important topic of the autonomous nervous system. So let us begin. The question we have here is classify beta blockers. Write the pharmacological actions, therapeutic uses, adverse effects, contraindications, drug interactions of beta blockers, propranolol. Mention the advantages of cardioselective beta blockers. So first we will be looking into the classification. We have the first generation beta blockers, second generation and the third generation. First generation are also known as non-selective beta blockers. They block beta 1, beta 2 as well as beta 3. Therefore equally, they block all these receptors equally. Therefore they are known as non-selective beta blockers. In second generation we have cardioselective beta blockers. That is, in this generation the drugs block beta 1 receptor more than they block beta 2 and beta 3. As we all know, beta 1 receptor is present on heart as well as kidney. Therefore these drugs are known as cardioselective beta blockers. In the third generation they have a special property, that is vasodilator property. So the drugs that come under these generations, that is the first generation, you can remember it with the mnemonic P3-STAN, STN. Okay, P3-STAN, that is propranolol, pindolol, penbutalol, sotalol, timolol and nadolol. P3-STAN, STN. Next, the second generation beta blockers, you can remember it with the mnemonic B-ARM, right? B-ARM, that is bisoprolol, ismolol, acebutolol, atenolol and metoprolol. Then the third generation with drugs that have vasodilatory property, we have carbidolol, cartelol, labetalol, nebivolol and celiprolol. Moving on, the pharmacological actions. We will be looking under the pharmacological actions under the following headings, that is CVS in heart and blood vessels, respiratory tract, CNS, local anesthetic, metabolic, skeletal muscle, eye as well as uterus. So let us look into each one of them in detail. The first is CVS. In CVS we are going to be covering the heart. As I told you, beta 1 receptor is present on the heart, and its action was it used to stimulate the SA node, it used to stimulate the AV node, which would used to increase, there used to be increase in heart rate, there used to be increase in force of contraction. When we talk about beta blockers, this action is going to get blocked. So therefore there is decrease in heart rate, decrease in force of contraction, decrease in cardiac output. There is decrease in ventricular dimension in normal subjects. There is decrease in cardiac work. There is decrease in oxygen consumption. The total coronary flow is also decreased in subepicardial region. Why is this happening? Because there is a block of dilatory beta receptors. Recall that in blood vessels we had alpha 1 and beta 2 receptors. This is getting blocked, which was responsible for dilation. So there is no dilation taking place. So therefore the total coronary flow is also decreased. Like when a vessel dilates, more blood flow, there's increase in blood flow. Now when a vessel does not dilate or it just constricts, so therefore the blood flow will be less. The overall effect in an angina patient will be the oxygen supply upon the demand status improvement. That is, if an organ is there, like any tissue is there, okay, for that the oxygen supply is increased than the demand status of that organ. How much oxygen that organ needs, more than that we are able to provide oxygen. So that effect is seen in angina patient, as well as there is increase in exercise tolerance. Moving on to the blood vessels, propranolol blocks vasodilation and fall in BP that is caused by isoprenaline. I told you, right? In blood vessels we have alpha 1, beta 2, and you can remember it by A, B, C, D. Alpha does vasoconstriction and beta does vasodilation. So it blocks vasodilation and fall in BP, which is caused by isoprenaline, and it enhances the rise in BP that is caused by adrenaline. Now it also this is one line from the textbook, that is KDT. That is re-reversal. It also does re-reversal of vasomotor reversal is seen after alpha blockage. So what does this sentence mean? Re-reversal of vasomotor reversal is seen after alpha blockage. So we will break this sentence down one by one, and we will uh, learn about the meaning of this sentence. First of all, what is vasomotor reversal? It is also known as vasomotor reversal of Dale. So what is vasomotor reversal? It is a phenomena that occurs when adrenaline only decreases BP through beta 2 receptor activation. Usually, what does adrenaline do? Adrenaline acts on all the receptors, that is alpha 1, alpha 2, beta 1, beta 2, and beta 3. But in this phenomena, adrenaline only decreases BP through beta 2 receptor activation. It occurs when alpha 1 receptors are blocked with the help of an alpha blocker. So this is your blood vessels. The alpha 1 receptors are blocked with the help of an alpha blocker, and now this adrenaline is only able to act on the beta 2 receptors. Beta 2 receptor causes vasodilation, because of which there is a fall in BP. Right, so this phenomena is known as vasomotor reversal of Dale. Now, what does re-reversal mean? Re-reversal means this involves blocking of beta 2 receptors. This receptor is also blocked after vasomotor reversal has occurred. So when I block this receptor also after this phenomena takes place, it is known as re-reversal. So they are telling us that propranolol also involves, when we use propranolol, there is re-reversal of vasomotor reversal is seen after alpha blockage. Makes sense, right? So this is there. Re-reversal what do we use? We use of beta blocker, that is propranolol. So moving on to the next point, that is propranolol does not have any direct action of blood on blood vessels, so very little acute changes are usually seen. Okay, so on prolonged administration, it leads to fall in BP in hypertensive patients and not in normotensive. That is, in normal people, it does not lead to fall in BP, but it leads to fall in BP in hypertensive patients when on prolonged administration. Normal dose or something, like it does not have any very much direct effect on blood vessels, so very little acute changes are seen. Okay, so the most likely explanation of antihypertensive action is because of this phenomena. See, I told you, on prolonged administration, there's decrease in BP. Decrease in BP is only known as what? Antihypertensive phenomena. Now, why this is taking place? The most likely explanation for this is the following thing. That is, the total peripheral resistance, it is known as TPR, is increased initially. Why? Because of beta 2 action of vasodilation is blocked. Now, the vasodilation is not taking place. Right. So, see, vasodilation is not taking place. Therefore, total peripheral resistance is increased. Like, this is the blood vessel. What do you mean by total peripheral resistance? The blood flow, because of blood flow, there's resistance occurring on this blood vessel. This resistance is increased. Why? Because there is no dilation taking place. Makes sense, right? And alpha 1 usually does contraction, vasoconstriction. So the total peripheral resistance is initially increased, because of which the cardiac output is also decreased. Okay, and there's decrease in cardiac output. See, resistance is increased, that means usually the blood flow will be slow, because of which cardiac output, there's decrease in blood flow also, cardiac output is also decreased. You can remember it this way. And alpha 1 is also, it helps in vasoconstriction, so cardiac output is again decreased. So, and the next thing is, continued treatment, the resistant vessels will adapt to decrease in cardiac output, and therefore what will happen? The total peripheral resistance will decrease. So now both systolic as well as diastolic BP will fall. This is the most common explanation of antihypertensive action. I hope you understood this point. In this point, what is happening is that the resistant vessels, on continued treatment, they will start adapting to it. They will adapt to the decreased blood flow, and therefore everything becomes like, there initially it was increased, now total peripheral resistance decreases. So now we can see both systolic as well as diastolic BP will fall. So this is the most common explanation of antihypertensive action. Other mechanisms include this decrease in renin release from the kidney. See, I told you beta 1 receptor was present on heart as well as on kidney. So this is not happening here. So there's decrease in renin. Renin release is decreased. If you increase renin, what used to happen? There used to be increase in blood pressure. Now renin is decreased, so BP is also decreased. This is one of the reason for antihypertensive actions. And the second thing is central action, reducing sympathetic outflow. Unlike it acts on the brain, the central action reducing sympathetic outflow. Some beta blockers that penetrate the brain poorly are effective antihypertensives. Okay, so yeah, moving on to the next organ, that is your respiratory tract. So recall, beta 2 receptors were present on liver, pancreas, skeletal muscle as well as on smooth muscle. In smooth muscle we had read that in RS what used to happen, it used to be bronchodilation taking place, but like this is the normal action that used to take place. But now that we are giving beta blockers, bronchodilation will not take place because the action of bronchodilation is blocked. So it can lead to bronchoconstriction. So therefore, propranolol, what it does is it increases the bronchial resistance by blocking beta 2 receptors. Normally this effect is not seen in normal people. Like in normal people this effect is not seen that much, okay, because it's just it is blocking their bronchodilation and not much effect is seen. But in asthmatics, what will happen in asthmatics, there's already asthma is because of bronchoconstriction and you're blocking the bronchodilation, which will cause some relief to asthma patients. So now there's increase in bronchoconstriction. So in this condition, if we give beta 2 receptors, the condition is consistently worsened and severe attack will precipitate. I hope you understood that why in asthmatics we should not give beta blockers, because asthma is caused only because of bronchoconstriction and you are also blocking the bronchodilation effect. So there's like too much bronchoconstriction, you can remember it that way, and severe attack will precipitate. Moving on to CNS, there is no overt central effects are produced. There can be some subtle behavioral changes, forgetfulness, increased in dreaming and nightmares. This happens because of long-term use of increased doses. So not much effect is seen, but if you use it for a longer time and you use heavy doses, then you can experience some subtle behavioral changes, forgetfulness, increase in dreaming and nightmares. Moving on to local anesthetics. So beta blockers also act as a potent local anesthetics as a lidocaine. Lidocaine is also known as lignocaine. Okay, but we do not use it clinically because it causes irritation at the injured site. Metabolic. It blocks lipolysis. What does lipolysis mean? That is breaking of fat, right? So it blocks lipolysis. Like lipolysis is nothing but like lysis in the sense breaking, right? So in general, in layman language, can call it that there's no breaking down of fats, like that is there is no metabolism of fats taking place. So what will happen, there will be increased levels of in the plasma, there will be increased levels of free fatty acid. Okay, plasma triglyceride level is also increased, LDL to HDL ratio is also increased. These are all very bad. These are all like very bad things. It can lead to dyslipidemia. Okay, so this will lead to dyslipidemia. I hope you got it. And then what will happen, it also inhibits glycogenolysis in the heart. Look at this, glycogenolysis. What does glycogenolysis mean? Glycogenolysis, see, glycogen you can see here. So lysis in the sense breakdown, right? Breakdown of glycogen is not taking place in the heart, in skeletal muscle, in liver, which usually occurs due to adrenal release during hypoglycemia, right? When hypoglycemia takes place, hypoglycemia in the sense there is less sugar in the blood. Imagine like you're hungry or like you're running fast, there's less sugar in your blood, so there's adrenal release. But if that person is taking beta blockers, what is happening, glycogenolysis is inhibited, right? So and that is recovery from insulin action is delayed. What does this sentence mean, recovery from insulin action is delayed? Recovery from insulin, what does insulin cause? Insulin causes hypoglycemia, right? So we can, the same thing we can put it in another sentence, that is, recovery from insulin action is delayed. Insulin causes hypoglycemia, and to overcome hypoglycemia we need more sugar in the blood. And how is this produced? By breakdown of glycogen. But this action is inhibited because of whom? Because of beta blockers. I hope you understood this sentence. Moving on, prolonged propranolol will lead to decrease in carbohydrate tolerance by decreasing insulin release. The next organ we have to look at is on skeletal muscle. See, I told you, right? Beta 2 acts on smooth muscle, skeletal muscle. In skeletal muscle, what it used to do was it used to promote, like, it used to stimulate tremors. Now, because obviously we are giving beta blockers, what is happening? The tremors are inhibited. In eyes, there's reduce in production of aqueous humor. In uterus, the relaxation of uterus is blocked. Normal uterine activity is not that much affected. Moving on to the uses of beta blockers. So we will divide it as such, that is, the drugs that block only beta 1 receptors and the drugs that block both beta 1 as well as beta 2 receptors. Drugs that block only beta 1 receptors, they are we mainly use cardioselective beta blockers. So as you know, beta 1 receptor is present on heart as well as on kidney, but because we are blocking them, what is happening? It will inhibit the SA node, because of which there is decrease in heart rate. It will inhibit AV node, because of which there is decrease in conductivity. It will inhibit myocardial contractility, because of which there is decrease in cardiac output, decrease in oxygen demand of the heart. So we can use all of this in patients with stable angina, myocardial infarction, arrhythmias, that is tachycardia, flutter, fibrillation, aortic dissection, HOCM, and chronic heart failure. That is, both of these reduce cardiac hypertrophy. Okay, HOCM full form is hypertrophic obstructive cardiac myopathy. Now, the second action was on kidney. Kidney, what it does, it reduces renin release. It inhibits the RAS pathway, because of which there is decrease in BP. It is used in antihypertensive drug. So if a patient comes with such a condition, that is, he has hypertension as well as he has stable angina, MI, HOCM, aortic dissection, the drug of choice will be beta blockers, mainly cardioselective beta blockers, because he has all these problems. And hypertension also we give it because it acts as an antihypertensive, as we saw kidney and all the other things which I explained in the blood vessels. Now the second thing is it blocks beta 2 also, that is, it blocks beta 1 as well as beta 2. Okay, so we can use non-selective beta blockers drugs, such as most commonly used is propranolol. So the uses of propranolol, you can memorize it with the help of a mnemonic, that is P4 heat, that is, there are 4 P's. Okay, it is a drug of choice in prophylaxis of migraine, pheochromocytoma, performance anxiety, as well as portal hypertension, that is, it prevents bleeding from esophageal varices. H for hemangioma, essential tremors, akathisia, that is anxiety like situation due to antipsychotic drug, and it is also used in thyroid storm. Thyroid storm means there are thyroid tremors as well as thyroid toxicosis. Now, the adverse effects of beta blockers. So, due to block of beta 1 receptors, due to beta 1 block, the side effect that can be seen is we can see bradycardia, we can see AV node block. Obviously, see, look, there's nothing to by heart in pharmacology. You need to know the basics, and you can think and you can write your own answer. Look, see, because of beta 1 block, where is beta 1 present? On the heart, right? So if I'm blocking that, what can be the adverse effect? It can lead to, there'll be too much decrease in heart rate. Too much decrease in heart rate is known as what? Bradycardia. That it can lead to AV node block. Yes, makes sense. Now, due to beta 2 block, where is beta 2 receptor present? It is present in 4 places. Recall: skeletal muscle, smooth muscle, pancreas, as well as liver, right? So it will lead to bronchoconstriction. Yes, because usually beta 2 leads to bronchodilation, but that effect is not happening because we are blocking that effect. So, what is happening? Bronchoconstriction. It can lead to a side effect that is nothing but your bronchoconstriction. So, it can cause asthma, and in COPD patients, it can lead to a side effect like a more severe side effect in asthma and COPD patients, or yeah, right. And it can also lead to vasoconstriction, that is it can cause diseases such as peripheral vascular disease, Raynaud's disease, vasospastic angina. Then it can also cause diabetes as well as there's risk of diabetes as well as dyslipidemia risk. Why is this? I explained it in detail. Why dyslipidemia? I told you because there is do you want me to go back to that page? Diabetes is because there is inhibition of glycogenolysis. See, there's inhibition of glycogenolysis, so the recovery from insulin is delayed. So there's increased risk of diabetes. That is, there's increased risk of so the increased risk of diabetes. Because of this, there is increased risk of dyslipidemia. You can remember it that way. So these were the adverse effects of beta blockers. Okay, now contraindications. Contraindications, see, non-selective beta blockers are contraindicated in both in all these, like in both of these. If a patient comes and he has bradycardia, he has AV node block, will you give non-selective beta blocker? No, because it will block this and it will lead to more decrease in heart rate. It will increase bradycardia, right? So obviously non-selective beta blockers are contraindicated in patient that has these two, and it is also contraindicated in patients that are asthma patients, COPD patients. All the patients that have these non-selective beta blocker are contraindicated. Why? Because it will lead to increase in all of this. If there is an asthma patient and I'm giving him non-selective beta blocker, what will happen? It will block the bronchodilation. It will further increase in asthma, right? It's a similar thing applies over here. So therefore, obviously, it is contraindicated in both of these. Now, cardioselective beta blockers, that is, it acts more on beta 1, right? So obviously, it needs to be contraindicated in a person who has bradycardia as well as AV node block. But can I give cardioselective beta blockers in patients like these? Look, absolutely we can give it in them because it is not blocking beta 2 receptor more. It is only blocking beta 1 receptor more. So if a person has asthma and I'm giving him cardioselective beta blocker, it is not going to increase the effect of bronchoconstriction because it is not acting on beta 2 receptors altogether. Where is it acting? It is acting only on beta 1 receptors, right? Like more prominently, it is acting on beta 1 receptors. So all these patients are safe. So the thing is, in all these patients, if I have to give a beta blocker, which beta blocker will I give? I will give cardioselective beta blocker. Got to know? So this is nothing but the advantage of cardioselective beta blocker over non-selectives. Look, there's nothing to by heart. If you know the contraindications, you know this also. What is the advantage of cardioselective beta blocker over non-selective? Is that in this case, that is in all these conditions, asthma, COPD patients, PVD, Raynaud's disease, vasospastic angina, diabetes, dyslipidemia, I can give cardioselective beta blocker. See, it is safer in asthma, COPD patients, diabetes, dyslipidemia patients. Okay, and just remember this, that propranolol is given in stable angina and chronic heart failure, but it is contraindicated in vasospastic angina, acute heart failure. Okay, we give beta agonist. Propranolol is non-selective beta blocker. So the next and the last part of this big topic, beta blockers, is the drug interactions. So the drug interactions are, see, there is additive depression of sinus node and AV conduction with digitalis and verapamil. So cardiac arrest can happen. Digitalis and verapamil, these drugs you will be learning in CVS chapter. So when we give beta blockers along with digitalis and verapamil, cardiac arrest can happen because they all have similar effect. They will lead to depression of sinus node, that is SA node, and AV conduction. So cardiac arrest can happen. Propranolol delays the recovery from hypoglycemia due to insulin. I've already explained this point, and oral anti-diabetics. So what is happening because of this? The warning signs of hypoglycemia. So it's propranolol delays recovery from hypoglycemia, right? So there is increased hypoglycemia, but along with this, what this propranolol is doing is also blocking the warning signs of hypoglycemia that is mediated by sympathetic stimulations like tachycardia and tremors. These are also suppressed. First of all, it is almost delaying the recovery of hypoglycemia, and when there is hypoglycemia, obviously the patient produces some symptoms like tremors and tachycardia. These symptoms that are caused is also blocked by beta blockers, such as propranolol. Why? Because tachycardia and tremors, right? Tremors is caused due to beta 2 blockage, tachycardia. So all of this is blocked. So it is very dangerous. Moving on, phenylephrine, epinephrine, and other alpha agonists present in cold in remedies can cause increased rise in BP due to blockage of sympathetic vasodilation. Yeah, if I'm giving beta blockers along with alpha agonist, what is going to happen? Obviously, see alpha 1, beta 2, this effect is block vasodilation. Though is not happening, and in alpha 1 agonist I'm giving vasoconstriction is happening, which will lead to increase in BP. Okay, when I combine it with phenylephrine and epinephrine. Next, cimetidine. Cimetidine inhibits propranolol metabolism, but dosage range of propranolol is very wide. Therefore, it is not clinically significant. Okay. Now, propranolol retards lidocaine metabolism by decreasing hepatic blood flow. Propranolol also increases bioavailability. What is BA? It is bioavailability of chlorpromazine. Chlorpromazine, it is an antipsychotic drug by decreasing first pass metabolism. First pass metabolism is caused by liver. Propranolol decreases the first pass metabolism of chlorpromazine, because of which the availability of chlorpromazine in the body is increased. I hope you guys understood this video. I hope you guys understood everything about beta blockers. So thank you for watching this video. I'll be seeing you guys in the next video. Thank you for watching.